Hello, welcome all to the Retrograde CTO Academy session 4. Initial we discussed about the basic hardwares, basic methods, and basics of various techniques. Now coming on to the second technique, that is retrograde wire true to true lumen. So in this particular case, I would be discussing how to go retrograde true to true lumen. So this is a case-based discussion. So coming on to this, what are the basics? So first of all, we'll take the both injections, and if you find a particular, in this case, if you see a CTO, and if you are not able to negotiate the wire anti-gradely, then of course we can go, if we have a good interventionist collateral from the opposite artery through the good interventionist collateral via wire into the uh, true lumen, from the distal lumen to the CTO segment to the proximal true lumen. So usually we are successful in 20 up to 10 to 15 to 20%. So it's a 15 to 20% of the time we can take this wire from true to true lumen, because what is the thing is that keeps helping in this case is the usually the distal part of the CTO is soft as compared to the proximal part of the CTO or the body of the CTO. So when we negotiate the wire from the distal end of the CTO, many times it is easier as compared to the proximal part of the CTO. So this particular case, 65-year-old male, hypertensive, non-diabetic, presented with class 3 in China. He has a normal ejection fraction, and angiogram was done, which revealed multivessel disease. LADN's LCX had a significant disease, and this RC emits CTO filling retrogradely from CC2 from LAD. The plan was CABG oblique multivessel PCI. Syntax score was 31, and JCTO score for the RCA was 1. So the patient initially, this is the angiogram. We can appreciate that he has a disease in the LAD and circumflex and RCA CTU. So the segment looks short. So in this particular case, first RCA CTU was tried with filter FC wire over the balloon support, followed by filter XT. But the problem is that at the proximal end of the CTO, it has a branch. So uh, every time the wire was going into the small branch, so it made difficult, very difficult to escalate the wire, because we are not able to get into the this proximal cap of the CTO. So at this time, the RCA CTO was abandoned, and we did the PCI of the LAD and the circumflex. And for second attempt, we could see that we had in our mind that from proximal segment, we can see there was a small branch was coming, and the wire was going again into this. So again, the right femoral approach, fielder FC wire used to negotiate, but again and again, we can appreciate in this image that it is picking a small branch. We don't find a particular point to poke. So it was an ambiguity in that particular segment. So this time also the procedure was abandoned, and it was decided that we'll go retrograde in the third attempt. So this is how we took the guide, femoral guide EBU from the femoral. Then this Chion wire was taken, and 150 centimeter corset pro-axis microcatheter was used, and the surfing was done. But uh, after a lot of efforts, we were not able to get into the septal and to go into the distal part of the RCA. So various views was taken, and the various wires were exchanged, and now we did try the SUO 3 wire to negotiate across the various this septals across the LED stent, and ultimately after a lot of negotiations, we were able to negotiate this Corsair Pro across the jailed stent, and then distal cap of RCA was reached once we got the wire into the this collateral into the distal RCA. And now keeping this we were keeping the wire into the RCA and thought we can go ahead with this catheter with the help of the wire into the distal RCA integrate wire. So, but the proximal anti-gate wire was not going into the lumen. So this filter XTR was negotiated from the distal segment into the proximal segment. And fortunately, it got into the true lumen because this can happen in 10 to 20% of the time when the CTO segment is not that calcified. Then we can often succeed in going from distal uh, true lumen to the proximal true lumen after crossing the CTO segment. And over this, the Corsair Pro Access, after this was taken over this filter XTR into the right guiding by keeping this trapping balloon over there. So it gives support and the microcatheter could be advanced into the guide. And now, once the microcatheter reached the integrate guide, then over this extravasation with 330 centimeter RG3 was done through the right guiding catheter, and wire was crossed from the needle introducer over the TUI because it cannot come out to the TUI. So you have to keep an introducer needle and negotiate that distal, the end of the wire, a soft end of the wire from the inside the needle over the TUI. So then the things were simple. The distal microcatheter was pulled a bit into the distal, into the septals. Then the pre-dilatation of the lesion was done, and the procedure was done over the extrise RG3 wire. And distal RC also revealed the significant lesion, and two long discs were implanted from ostial to the distal RC. So this is how a good TIMI 3 flow was achieved. So we got from the retrograde true lumen to the true lumen, and over the externalized wire we did the PCI, and the cine safety was for the to was taken safety cine was taken to look for any collateral damage, and RG3 were pulled from the left guide after the gentle disengagement from the left main. So we have to be very careful to prevent the cheese cutting action of the this wire that is across the both gears. And at the end of the result, we see there was no injury to the septal collateral. So, take home from this presentation is that with the failed CTO retrograde approach would be of much help. And if we get a good interventionist collateral, then of course we should go ahead with the retrograde approach. And many times SO3 wire over Corsair Pro Access can be used to negotiate the collateral to reach the distal segment of the CTO. And many times kissing microcatheter techniques can be used to avoid the cheese cutting to prevent the collateral damage. So in 10 to 20% of the cases, it would be possible to go from retrograde true to true lumen. So this is how we discuss in this particular session. After in the first we discussed the kissing wire retrograde marker technique. Now in this particular session we discussed the distal true to true lumen crossing of the retrograde wire. This is can be done in 10 to 20% of the cases for the CTO to be a successful PCI to be done in case of a CTO in which the integrate technique has failed. So we would be coming in the next session how to do the card technique, and especially the knuckle card that is done in the calcified CTO. So thank you all for the patient listening.